I'm going to speak a little bit about how we use wearable technologies for climate health adaptation and looking at a lesson from Burkina Faso, because this is a very short talk, so you can read up in the papers. We publish quite a lot. So here you can see the overall schema of how we are working in these different countries and also in Burkina Faso. So essentially what we are faced with in these countries is that we don't have sufficient data to understand what is happening in terms of heat exposure and human health. So the first step is to establish new data collection mechanisms that actually enable us to understand what is happening to the health of people when faced with heat or other climate change related impacts. So here you can see the different components. First, we handed out individual sensors to people. So we gave them wearable devices, Garmin Vivo Smart. This is a consumer grade device which measures how much people move, how much they sleep during the night, and heart rate. We also conduct questionnaires. So these populations we work with are visited once a year and are asked questions about migration, also their health, if somebody has died or given birth. And we add new health assessments of climate-sensitive diseases, like, for example, COPD, but in Malaysia we also look into cardiovascular health. At the same time, we strengthen climate-related data, so we have established weather stations in these study areas, because oftentimes, or as you may know yourself, weather is very local. So the weather here and 10 kilometers else may be different. So if we don't measure, we don't really understand what people are exposed to. We also use remote sensing, so satellite-based images, and we've put the sensors that Hamima spoke about in the homes of people as well. And all of these data sets we put in something new, the graph database. You can read up on that in other papers as well if you're interested, which hopefully helps us to better understand risks in population. So these populations we work together with are spread in Africa and in Asia, and Burkina Faso, for example, which I'm going to talk about today in the next 2 minutes, is 120,000 people which have been followed up for over 30 years. So for over 30 years, once a year, somebody came to the homes and asked this questionnaire. So these cohorts allow us to do climate research, because we have these decade-long data on health. In this cohort, we are currently running this trial to understand lung diseases. So we observe 100 participants who have COPD and 100 participants who have not. How did we know? So we ran a standardized questionnaire, and if people showed with this questionnaire, so it's 10 questions, which gives you a likelihood if a person has COPD or not. If a person showed high likelihood, we did a spirometry measurement to confirm. And this is how we build up the cohorts. We gave them then the wearable device to understand how much people move, how much they sleep, and the heart rate, and also have the data from the weather station and the indoor sensors. However, what we were faced with, the spirometry measurement, I don't know if you've ever done this yourself, but it's not an easy measure. So basically you have to blow all the air of your lung at once out. So basically you do like a strange movement as well. So the problem was, how do you get rural low literacy participants to perform this abstract physiological maneuver correctly in like 40 degrees Celsius heat with an unfamiliar device, when even the concept of lung volume has no direct translation into their language. So these are the problems we are faced with, and what we did was that we asked the field workers to perform themselves, so completely exaggerating the movement, the sound that you do. We also found, for example, that women are quite shy. So because the field workers were oftentimes male, was that women were not really eager to show themselves, like, you know, with the whole movement and the sound in front of the male field workers. So we trained female trainers, and male trainers coached men. So we had kind of a gender division for the data collection. And we started to use local analogies to familiar acts, like, for example, cooling the porridge or starting a fire, so blowing in the fire. And there was also a bit of social reinforcement, so we tried to make the situations like in a group and, you know, less kind of intimidating, more laughter. What we found was, so we did this in phases, so we tried different kind of interventions, we called them, so like the gender matching, local analogies. And what we found found in the beginning it was like 14% accepted the spirometry measurement, and in the end, after running like all of these interventions, it was like 75%. Participant anxiety dropped, and in general, cooperation improved, which led us to the conclusion that cultural and behavioral adaptation can really transform data quality in low resource, high heat settings. Thank you.